All right, good evening again, everyone. My name is Dr. Ray Thal, and I'm joined with my panelists here, Dr. Craig Miller on the far right, Dr. Rajiv Pandaranath, and John Dale, physical therapist. Lonnie Davis was supposed to be joining us, and unfortunately, he's tied up in the OR. So hopefully, he will be able to join towards the end. This session is being recorded, so any of your friends who are not able to join us virtually here will be able to get it on our website. So tonight is one of a series of lectures that we're giving for the Washington Sports Medicine Institute, which is a division of Ortho Bethesda and Aligned Orthopedic Partners. And we're excited to talk about the treatment of shoulder instability. The format for tonight is I'll start with a presentation of the history, giving a historical perspective of the treatment of shoulder instability. And then I'll be the moderator for a panel discussion to get some viewpoints on different methods of treatment and how the treatment of shoulder instability has evolved and where we are in the current day. Okay, so again, these are our panelists that will be discussing after I continue my discussion. So shoulder instability has a very long history. If you look all the way back, the first recorded descriptions of shoulder dislocations go back to the ancient Egyptian tombs. There are tomb paintings that show patients with shoulder dislocations and attempted treatments. The first real written description dates back to around 400 BC with Hippocrates, the father of modern medicine. And he described multiple shoulder reduction techniques, dislocated shoulders. And a couple of interesting things that I've learned about Hippocrates and his view on the treatment of shoulder instability. It wasn't just as we view it today as a bit of a disability and a quality of life issue. It was actually a matter of life and death. And if you see this quote, he says that the shoulder, which is subject to frequent dislocations, should be treated, for many persons have been obliged to abandon gymnastics exercises and have become inept in warlike practices and have thus perished. So this was a matter of life and death back in his day. Unfortunately, he didn't have the methods of treatment that we have. Their method of treatment was the red hot poker. But interesting, if you read about the methods that Hippocrates described, some of his colleagues in that day were using the red hot poker superior and posteriorly, and he claimed and had a better understanding, without an full understanding of the anatomy, that the red hot poker should be placed anterior and inferior, which turns out to be where the pathology is to this day. So while I think the one area that all of our panelists might agree is that we're fortunate to live in a day where we're not using a red hot poker, but we can appreciate Hippocrates' understanding even back BC. So the early published scientific literature really starts in the 1800s, where there were multiple reduction techniques that were described. Some of the early techniques of the foot in the axilla reduction had high complication rates, with injury to the axillary artery even reported. So various techniques were described. And it wasn't really till the late 1800s or early 1900s that we began to start to see some operative procedures described. There are various non-anatomic sling procedures, and most of them had universally poor results. Our modern understanding really is credited to Bankart, who preferred to actually be called Blundell-Bankart, and described the lesion that he thought was the essential lesion as disruption of the glenohumeral ligament and labrum off of the anterior glenoid. And this is the lesion that bears his name. Described this in 1923. And subsequent to that, through the 1900s, a variety of open treatment techniques have been established. And I put these in categories, and we'll go through each one to talk about just how each of these techniques have evolved and how the treatment has evolved. So Bankart, when he described his lesion, he actually modified a technique that had previously been described by Perthes in 1906. And his technique was to drill holes in the glenoid and to repair the Bankart lesion through these drill holes using silk sutures. He used a dental burr to create these drill holes, and even in today's day and age, it's a difficult operation, and certainly back in those days it was. And I think some of the evidence to demonstrate how difficult this procedure was is that even through the 1950s, people were trying to modify this capsular labral repair with other methods other than sutures through drill holes. So this is a report in 1956 of repair using barbed staples. So while the pathology was being recognized, the technique was still a challenge even through the 50s, and I think even to today. Because of the challenges with the arthroscopic or with the open Bankart repair, some non-anatomic procedures became popular. In the 40s, Magnuson and Stacks described a transposition of the subscapularis from the lesser tuberosity to the greater tuberosity, and putty plat was a popular procedure, which is a division and shortening of the subscap and the capsule, which both of these procedures had some degree of success, certainly a higher failure rate than we would think is common today or is acceptable today. But it was, but this was a procedure that allowed surgeons to more easily provide a repair, and certainly had the challenges or the concerns with the loss of external rotation. And it's because of the loss of external rotation that we were able to provide some increased stability, but at the expense of motion. In through the 80s, capsular imbrication and capsular shift procedures were performed. Neer described his laterally based inferior capsular shift procedure, which is still commonly used today, especially in cases of multidirectional instability. And Alchek modified that to a medially based T-plasty. Both of these procedures can be done in conjunction with a Bankart repair. So once we got into through the 1900s, there's an evolution that developed towards arthroscopic repairs. So let's talk a little bit about that. The first use of a scope in an orthopedic setting was actually in 1918. Tagaki used a cystoscope to examine a cadaveric knee, but image quality was poor, and it really didn't take hold until the mid-1950s when Watanabe continued to develop, all in Japan, the evolution of the arthroscope. 1967 was the first fiber optic scope, and Robert Jackson visited from North America, who practiced in Canada, visited Watanabe, and he is credited bringing the arthroscope to the United States. So in through the 70s, the development of fiber optics, television technology, the development of arthroscopic instruments and implants, people started to think about, can we use the arthroscope in a variety of joints in a variety of conditions, including can it be used for arthroscopic Bankart? And the advantages that surgeons in that time thought had potential was, one, giving circumferential visibility. It avoids some of the subscapularis complications that we had with some of the open procedures, and would it provide a minimally invasive technique for repairing this Bankart lesion? So obviously, this was a potential paradigm shift in the way that medicine had been practiced for many years. And I like to quote this book, The Structure of Scientific Revolution by Thomas Kuhn, who describes that a paradigm shift, a major change in the way that medicine is practiced, requires two things. One is product innovation, and the other is process innovation. And I think that you can see that while we had an arthroscope, we needed instrumentation, we needed equipment, we needed processes to really make this shift from open Bankart repair to the arthroscopic repair. So one of the early leaders, the early leader, I guess, was Lanny Johnson in 1980, decided to try to use staple for arthroscopic Bankart repair. And this was really the first arthroscopic Bankart repair described. There's a metal staple is shown here on the right. You can see as a large staple provided just really a single point of fixation, had a high recurrence rate and a high complication rate. You're putting a big metal staple, 26% of the staples loosened, and certainly the concern of large metal. But it was really the first step in this evolution process of transitioning from open procedure to an arthroscopic Bankart repair. Transglenoid sutures then became the next step. Morgan in 1987, and then my mentor, Dick Caspari, popularized the transglenoid repair. And this, for those of you who aren't familiar with it, multiple sutures are placed in the glenohumeral ligament, and then they're passed through a single transglenoid or sometimes two transglenoid drill holes, brought out through the infraspinatus fascia posteriorly, and then tied over the infraspinatus fascia. And Dick Caspari popularized this technique and was able to bring product innovation to allow this technique to really start to gain some traction. This was the suture patcher that he developed. Remember, in these early days, arthroscopic techniques needed equipment to be able to do our procedures. So he developed this suture patcher that allowed the passage of a monofilament suture that would be passed through using this little spin wheel at the end. And we would pass multiple monofilament sutures through the anterior inferior glenohumeral ligament, pass a transglenoid drill hole, and tie it posteriorly. So he was able to achieve multiple points of fixation in the glenohumeral ligament, unlike the staple technique that Lanny Johnson was using, but still a single point of fixation and tying over soft tissue. So these techniques, these early techniques, had significant resistance from the established shoulder surgeons. There were many shoulder surgeons who started to call the arthroscope the tool of the devil. They would say, well, why look through the keyhole when you can open the door? And some surgeons to this day may say that, I think. But certainly these are the resistance. So the question was whether these early surgeons were truly pioneers or were they just cowboys? And some people felt that this transition that we're making, this evolution from open to arthroscopic bank art, was really not an advancement at all. And that we needed to go back to the open techniques. So I think the real process or product development that allowed for this paradigm shift was the suture anchor. That was developed in 1989. And this was the first suture anchor, as you can see here, made by a company called Mitech, which was subsequently bought by Ethicon, a J&J company. And it had a single nitinol arc that you can insert through a drill hole and had a suture. And the beauty of this design was that this anchor started to be used by open surgeons to address the challenge of making those drill holes on the anterior glenoid. So many open surgeons began to use this, and arthroscopic surgeons started to think, well, this is an opportunity that maybe we can use this device and get the same method of fixation that you're achieving open, because the previous techniques, arthroscopic, obviously used techniques that could arguably be suboptimal and not the same technique that you were using open. The problem, though, this initial suture anchor was held to a knot, or the suture was held to a knot on this anchor, and it didn't slide. So that made for knot tying difficult, and we needed to advance that process. So in 1991, this generation 2 anchor developed, had two arcs, and had a suture that would slide. And subsequently, Gene Wolfe in this group, my friend John Richmond, reported the first case of arthroscopic bank art using suture anchors. That was in 1991. So this was a technique that they used. And interestingly, again, while we had a new product, we still needed a process. So the question is, how do you pass the sutures? How do you then tie knots? So in those days, there were really just suture hooks. So you would pass the suture, as you can see here, through the glenohumeral ligament. And then once the suture was passed, you would then thread the suture through the anchor, then insert your anchor, and then now you have to then tie a knot. And they were using a fisherman's knot to tie these, but they reported a small case, a small series of patients who had arthroscopic suture anchor repairs. And this obviously got the excitement of many people. I was a young surgeon at the time, and I was one of them who was excited about the opportunity that here maybe we are able to address this bank art lesion with a method of fixation that gives multiple points of fixation on the glenoid, multiple points of fixation, and can we truly arthroscopically create a repair that's similar to the repair that's done open? So many surgeons began to look at this, try to develop techniques and equipment to allow us to do this. And as we were going through this process, there were many concerns and challenges. One was the arthroscopic knots were unfamiliar. The sutures we were using are not the high-strength sutures that we enjoy today, but they were Ethibond sutures. And they, if you tried to secure your knot a little bit too much, these sutures would break. And I can't tell you how heartbreaking that was to put in an anchor, go through the trouble of passing your suture, and have your suture break. There was variability in the arthroscopic knot security. We weren't sure exactly what the arthroscopic knots, truly were going to be most effective. And lastly was the problem of prominent knots. When the Bankart repair is done open, the knots are tied outside the joint, but here with an arthroscopic repair, we're tying knots intra-articularly. And the question is, do these prominent knots cause scuff on the articular cartilage and squeaking down the road? So these were concerns that I, as a young surgeon, and many of the other surgeons of that generation began to think about how we can overcome some of these challenges. A study in 1995 came out showing where they compared the quality of arthroscopically tied knots to open tied knots and found that the loop holding capacity of the hand tied knots was superior to the same knot tied using a pusher. And there have been subsequent studies that have also questioned our efficacy of tying arthroscopic knots. So given those concerns, some people went back to the idea of attack. J.P. Warner in 1995 described a series of his patients using a bioabsorbable tack. So going back to the idea of attack, saying let's abandon the suture, the knot tying process, and use attack. I got interested in this and developed the first knotless suture anchor, which was a suture anchor that allowed for Bankart repair without using a suture anchor, but without having to tie a knot. And we first in '98 released one that was metal, and then subsequently absorbable, now a biocomposite version. And this anchor, the way this anchor worked is that we replaced the long strands of suture on the anchor with a loop of suture. And then, as you can see, this loop of suture is pulled through the bunion ligament using utility suture, and then the loop is captured in a little notch at the tip of the anchor. And then the anchor is then inserted into the drill hole, and then you tension the repair by the depth that the anchor is inserted. So it depends on quality of bone, and fortunately in the glenoid, the quality bone is typically good. So as the anchor inserts, it will lock in place, and you can tension the repair nicely. This procedure, while we had a new product, we still needed a process innovation because the methods of passing this utility suture hadn't been established. So I also wrote a paper describing the use of the Caspari suture punch, which was really the best suture punch on the market, and really the only suture punch on the market in the day, by passing a loop of suture through the Caspari punch, which was originally designed to pass just a single monofilament, and using that loop as a passing suture to pull the utility suture. But we found that with this device, we were able to achieve a low-profile repair. We did biomechanical studies to show pull-out strengths were comparable to open, and we avoided the knot tying process. This was the first of the knotless anchors that have subsequently been developed. Now, there are obviously many other surgeons who brought many wonderful ideas, and the suture anchor market exploded through the 1990s and 2000s with a variety of different materials, methods of fixation, number of sutures that are on the anchors, even now to modern day all suture anchors. And similarly, the knotless suture anchor market exploded, in a variety of different methods for achieving knotless fixation have been developed. Multiple companies have developed now a very popular the push lock and swivel lock anchors, and now there are many that are similar to those that similar to the knotless anchor that I devised allow for knotless fixation. So we had now fixation methods, but in order to really achieve this paradigm shift, we needed additional instrument innovation, which occurred during this very exciting period with shavers, hand instruments, drill guides, a variety of different equipment, arthroscopic extremity holders, cannulas. So the world really exploded with arthroscopic equipment and arthroscopic innovation, to the point that by the mid-2000s, the majority of the Bankart repairs were being performed arthroscopically. Even from 2004 to 2009, we jumped to almost 90% of the cases being done, according to a report in 2014. So clearly this evolution was occurring. The other advance that the arthroscope provided was a better understanding of the pathology. So I mentioned that Bankart felt that the Bankart lesion was the essential lesion. But we've learned that that's not the only lesion, and that there are multiple other things that contribute to instability in a traumatic setting. So the other thing we learned is the importance of positioning of the ligament. So with arthroscopic repairs, we don't want to just shift. We want to shift superior. This is a vertical problem. It's not just a repair from side to side. We need to, with any repair technique, shift the ligament superiorly. Tom Deviser described a variant of a Bankart lesion called the Alpsa lesion. This was in 1993. The anterior labral periosteal sleeve avulsion, where the labrum avulses off of the glenoid rim, but the periosteum remains intact and the ligament shifts inferiorly. In an acute setting like this, it's easy to see that, but in a chronic setting, it looks like capsular redundancy, because this all scars in, and it's important to recognize that the labrum can be sitting down inferiorly. It's important to look from the front of the shoulder to see that. Gene Wolfe in 95 described the humeral avulsion, or the Hagel lesion, and this is just yet another pathology that I think we've learned because of the advent of the arthroscope. And then understanding that capsular stretch occurs in many of these patients, and then the question is, how do we address that? And then in recent years, the importance of bone deficiency. Burkhart, De Beer in 2000 reported on their understanding of the importance of bone deficiency. We'll talk more about that in a moment. So arthroscopic Bankart repair was not just a rocket ship in a linear movement, in a linear way. There were fits and starts, as you might imagine, and innovation. Everything new isn't always better, as I would say. So as we understood that capsular stretch was important, we realized that some of the new techniques didn't necessarily lead to an advance. So for a period of time, the thermal capsular came into popularity. And again, many surgeons thought, okay, this might be an easy way. It's kind of the hot poker revisited, where we were burning the anterior capsule, and it really caught on for many years until the follow-up demonstrated significant challenges, significant complications, and significant recurrent instability. So this was one of the cases that I point out to show that the evolution is not necessarily linear, and I think as we go forward, we'll continue to have fits and starts. We'll have 2 steps forward, 1 step back, and this was one of the 1 steps back. The complications that we saw were things like axillary nerve injury, over tightening if the tissue scarred, and in several cases, this is a case that I saw, a patient who had a thermal capsulorrhaphy, and there was capsular damage, which creates a challenging revision scenario. So we did address that the capsule laxity needs to be addressed. So arthroscopic techniques have evolved now for capsular plication. In addition to the Bankart repair, you can plicate with separate sutures, capsular plications horizontally or vertically. You can plicate the tissue to the labrum, or my preferred technique is actually to incorporate the plication into the labral repair. Take a tuck of capsule through the labrum and then attach to an anchor to get a firmer fixation. So again, improved understanding. This kind of landmark article by Steve Burkhart and Joe De Beer demonstrated the importance of bony lesions and discussed the inverted pear and Hill-Sachs lesion. And I think over the last several years, this has been a renewed interest to most surgeons to understand why some of our previous arthroscopic repairs had failed. And it brought into being the thoughts and technology of the engaging the Hill-Sachs lesion. What is critical bone loss, on-track and off-track lesions? And these are topics that we could spend hours discussing. But it was this study that caused surgeons to start to think of these procedures. And the evolution then took a step to start to reconsider some of the bone procedures that were done in the 50s. So Latarjet described a procedure of a coracoid transfer. HealthFit, also Bristow and HealthFit described one in 1958, transferring the coracoid process with the attached conjoint tendon to the anterior glenoid. The difference being Latarjet's was a longer bit of coracoid bone, but to provide both bone to the anterior glenoid and having the chondroid tendon serve as a dynamic sling. And this has become, has gained renewed popularity, really based on that Bankart and De Beer study. The other technique that has gained some popularity in recent years is the use of free bone grafts to bone graft the glenoid. Iliac crest, the Eden Hebernet, distal tibial allograft, and distal clavicle allograft. And some of the renewed interest in these procedures is because there is interest in can these procedures be done arthroscopically? And we're starting to see some arthroscopic instrumentation and techniques being developed that the hope is that we may be able to avoid some of the complications that we see with screw fixation and possibly be able to do these same procedures arthroscopically. Some of the arthroscopic ladder J's that have been done early are technically quite challenging. So I think the charge to surgeons of today is, can we incorporate some of the principles that we've learned about the importance of bone loss, but still take advantage of the minimally invasive procedure to do these procedures arthroscopically. And I think that may be the direction that we'll see happen in the future. The other area that needs to be addressed is the Hill-Sachs deformity. And there's been renewed interest in a procedure called the remplissage. Remplissage is a French word meaning to fill. And Gene Wolfe described an arthroscopic procedure where placing suture anchors in the Hill-Sachs deformity and then passing sutures through the posterior capsule and infraspinatus and tying that. So essentially making this Hill-Sachs deformity, taking it from being an intra-articular defect to an extra-articular defect. And this has gained significant popularity. There are tensionable knotless anchors now that have simplified this procedure, and it's gained significant interest to be performed in conjunction with an arthroscopic Bankart repair. And here you can see a Hill-Sachs lesion that has this linked tensionable anchors and remplissage being performed here. So this is a 30,000 foot view of the history dating back to the ancient Egyptians, and I think that my goal is that it helps us to understand where we've come. We all enter medicine at different stages. We jump on this moving train, and we understand where we are currently. But I think that there's great value in seeing how things are done, how things have been done, how our predecessors treated these problems, and I think Isaac Newton summed it up best by saying that if I could see further than others, is by standing on the shoulder of giants. And I think that we had many colleagues before us that have taught us, and it's important to continue to recognize and appreciate how we got to where we are and have the benefit of the options that we have to treat our patients. So I thought we would then move on to a panel discussion. And I thought maybe we'd start before. I have several cases that I thought I'd present to our panelists to bring on some discussion. I think it's important in my mind to realize that if I've learned anything over the years, it's that there are many right ways to treat things. And I think you may hear some differences of opinion here tonight, which I think is a good thing. And I think there are many right ways. So I think that I would like to start. Maybe we'll go with in order of seniority. We'll start with Dr. Miller and see if love to hear your thoughts on where we've progressed, how the treatment of shoulder instability has evolved, some of the things that I've discussed, and what's your perspective, and how do you have kind of a general, I know there are a lot of variables that we treat, but maybe some of your general thoughts as to where you think we've come with Bankart repair or treatment of shoulder instability, and maybe where you think we might be going in the future.
Thanks, Ray. That was amazing overview and historical review of instability. I think there's nothing to make you feel your age more than doing a historical review and realizing that you've seen kind of the entire arc of treatment. I think you and I kind of really were in the sweet spot of this. We really were. You're a couple years older than me. You were really at the outset. With your innovation was pivotal to developing the Nautilus anchor, was a game changer in the early days of arthroscopic instability. And having trained in the 90s and early 2000s, pretty much every anchor you threw up there, I'd used at one point or another. You stole some of my thunder with the topaz, because I was like, the hot poker, we did that. We were guilty of striping the inferior glenohumeral capsule with these topaz and these electric cautery devices.
Right. And as we're studying, should we stripe, should we cross?
Yeah, cross. And then I had the pleasure of then seeing those in fellowship and going with Jim Taboni and having to do capsular reconstructions, taking allografts. These poor young athletes who had no capsule left, that had been completely burned and melted away. It was absolutely tragic.
But that's the way evolution occurs. That's the way progress.
Unfortunately, we don't. You're right. Unfortunately, some people end up being guinea pigs. We used the short tack. That was the short that Glassman used that, and those would reabsorb within weeks or months and led to failures. I also worked when I started working with Frank Jobe, when we did transosseous tunnels. We had these special forceps that would just grind through the inferior glenoid neck, very, very strong. And he was just
operation,
just did one today. Yeah, it is still very open pancreas is a very challenging procedure. But I think I'll go into. We'll talk in a second why when I think it's appropriate still. I think at this point in my career, we've, as you would echo, we've lived through these results in real time, and fortunately, probably or unfortunately, our personal results kind of follow that of the literature. We've had to see and deal with our failures, and nothing ruins outcomes better than long-term follow-up, right, for all of us. And that's really led to me dramatically changing the way I treat instability in the last 5 or 10 years. Going back to the basics. I think we're going to find out tonight as we talk that we have to be humble and recognize that much of the literature we quote is small sample sizes and not really very rigorous scientifically. So that's what leads to these fun discussions, because we can sit here and bore ourselves to our audience to tears of what is the appropriate way to treat each individual. I think that personally, I've developed some algorithms, and like I've said, I've become much more open to open surgery. Once again, I had the good fortune, as you, of being trained by a lot of open shoulder surgeons back in the day, and I'm very comfortable. And I will take offense. I think if we go back at the arthroscopy literature, I could swear some of the earliest arthroscopy was done at the Hospital of Joint Diseases in the 1920s and 30s with Dr. Berman. I think he was one of the first. Yeah, I think so. I'll have to go back and look at it. I was looking at it. There's something. So, but at my own mind. But anyway, so generally speaking, I think we have to be. There's so many factors, and there've been so many different algorithms developed by people to treat instability. I think that has to be recognized that having an unstable shoulder is a life stress event. It is a major life stress event to have a shoulder that's dislocated, whether it be in 300 BC in a war where if you lift your arm to stab your opponent and your arm dislocates, game over for you, but also for our patients today. We really want to do our best to eliminate instability, because your best chance at a successful outcome is your first chance with all these procedures. So you want to develop an algorithm for yourself that you feel gives the best outcome for your patients. And there are many variables that go into it. That's age, the soft tissue envelope that's involved, the labrum, the capsule, ligaments, the patient's physiology, generalized hypermobility, or are they just a loose shoulder without generalized hypermobility? Is there bone loss? And I'll tell you that, yes, there is bone loss. I mean, it's been well documented that probably in primary dislocators, it's about 20% of first-time dislocators have some degree of glenoid bone loss, and probably 90% or all have, 90% have glenoid-sided bone loss if there were recurrent dislocations. And with respect to the humeral side, probably 2/3 of patients have a hillside lesion to some depth, and 100% of any recurrent dislocator will have an indentation, whether it's on track or off. So, I mean, that being said, and I got to shut up because I'll keep talking. I think that okay, when I evaluate a patient, I'm very conservative still, and I tell patients, you know, and then we are as of yesterday. It's apropos to be here today because yesterday I had a 16-year-old football player who dislocated over the weekend, first time dislocator. And what are we going to treat? How are we going to treat this person? And I tell patients, really, 16-year-old football player, you're gonna probably dislocate again if you look at the literature. Is it 100%? Maybe not. Maybe it's 80%. But I always give patients the option. I think the military has pushed now to kind of treat these young athletes, and they're, but again, they're constructs, so the government wants to.
Let's hold up because one of my cases we're going to talk about first time dislocators.
So first time dislocators, I think without significant bone loss and someone who doesn't have any hypermobility, I think that an arthroscopic Bankart repair is absolutely is indicated.
Well, we'll get to that with the case discussion. With one of the cases, we'll talk about that.
I think, I just like one in my algorithm basically, but those are things I consider.
Yeah.
And I think, as we'll talk about as we get into, you'll ask me later, you know, arthritis, no arthritis, and some procedures. All right, thank you.
No, I think that's a good overview, and I think, So, Rajiv, you've trained a little more recently. Maybe you didn't.
Slightly.
You didn't see the hot poker techniques that Greg and I saw.
No, I only heard about them.
That's okay.
But my training was more in the late 2000s. So, according to your historical perspective, it's pretty accurate. It's a great talk. And pretty much when we saw a lot of the conversion, a lot less open Bankart repair, and a lot more arthroscopic techniques, and kind of I think the beginning of doing ladder J's in the United States, at least. So I think I missed some of the history of the Bankart repair. But I've also even in the last 15 years, I would say there's still even significant advances, both in the technologies that we have to do arthroscopic repairs and the techniques we have to even assess what people need.
Right.
And I like to look at a lot of different things when somebody walks into the office with a shoulder dislocation, because I think there's certainly age, there's their general ligamentous laxity. So I think that dislocations are often a combination of somebody's laxity and then whatever happened to them. So some people have a great story of having a traumatic injury and their shoulder dislocated. Other people, it doesn't sound like anything that would happen to you or I to dislocate our shoulders, but theirs certainly did. So, you know, some people get stuck for hours and go to the ER and have to get it put back in. Other people, even on their first dislocation, are just popping it back in themselves and not even really sure what happened.
Right.
And then, of course, some of the things that Craig talked about with the number of dislocations, the ease at which it comes out, but then also their desired activities. So I like to look at what sports do they play, what is important for that sport, and also what risk are they putting themselves in to play that sport.
Yeah. So one of the things I find interesting, you know, we all read the same literature now, but yet we come up with different conclusions sometimes, even a split between the U.S. surgeons and European surgeons. You know, so I think when we talk about the role of open surgery, role of ladder J versus an arthroscopic Bankart and remplissage, there's a big split across not just within the United States, but on both sides of the pond. So I think that's an interesting thing. I want to introduce John Dale, physical therapist who's been, we appreciate you joining. And curious to hear your thoughts from a physical therapy standpoint. I think it's, frequently, I always see instability as really a surgical problem. So you guys get to deal with them post-op.
Right.
But any thoughts that you have on some of the things that we've been talking about here?
Yeah, I mean, I think the biggest thing to me is, regardless of conservative or going with the surgical route, it's a long process. If you are going to go the conservative route, mean, it's not gonna be 3 visits and you're better. It's probably a dedicated 3 to 4 month shot at trying to not get surgery. You know, at that point, you could probably argue, would you be better off just getting it fixed and not dealing with the chance of recurrent dislocations?
Right.
So I think it's very much down to, you know, what's the history of this patient? Is it dominant versus non-dominant arm?
A lot of variables.
Right. Age, season, year. You know,
Right.
is this my senior year? I'm never going to play again.
Yeah. So
Yeah.
let's maybe talk about some more specific cases then. So I've put together a few cases that maybe will highlight some discussion that we can have here. So first one is, and these are all real life patients. So 27-year-old right hand dominant male, very active in judo, has an injury with judo 2 days prior to his office visit. States that his shoulder was dislocated for 5 minutes and he was able to manually self-reduce the shoulder. Active in a variety of sports, but is competitive in judo. Comes in, these are his x-rays, and of course, patients nowadays not only come in with their x-rays, but even though he's only 2 days out, he comes in with his MRI scan. So, why don't we start, maybe we'll go reverse order now, Rajiv. Maybe you could tell us your thoughts here on viewing this MRI scan and what you're thinking on this athlete. 27-year-old right hand dominant, active in judo.
Sure.
2 days out.
So I think one of the things my mentor has always told me is that when you're in a combat sport, you win if you dislocate the other person's shoulder. So that's certainly something that you got to think about when you're having this guy go back to sports. But that being said, I mean, if you go back to his x-rays, you can see he has a Hill-Sachs lesion on his humeral head as, you know, a sequelae of having the dislocation. He's got a Hill-Sachs lesion there, and then on his MRI, he's got a tear of his labrum with I don't see a lot of bone loss that I would call significant in this MRI. You can see on the.
Are you concerned with the Hill-Sachs lesion here?
I don't think it. You know, usually I'll take some measurements and stuff, but it doesn't look very deep. It looks fairly shallow.
Right.
And so no, I would probably don't anticipate doing much with that. Does look like there could be some tearing that extends into the posterior labrum as well on his axial MRI, and then on the sagittals, that might be some another shot of the labrum being off as well. But I think so if I'm concerned about a lot of bone loss here, I think a better study to get would be like a CT scan of the shoulder. But for this person, probably I would not do any more imaging at this point.
Okay. So what would you recommend for him? Would you recommend, well, I know you'll go on to Craig, would you recommend surgery right away? Would you recommend send him over to John?
Well, yeah, I think, like I said, I think that you have to go over all the options. I like to do shared decision making, I'm sure we all do. I think a 27-year-old guy who's competitive in judo wants to go back to judo. That's basically 100% dislocation rate. Even for 27, which, you know, you're already over that curve, you start to think, you know, late 20s, you're starting to get a little bit less likely to re-dislocate according to long-term data after a primary dislocation. But when you look at this constellation of findings, the level he competes at and the sport he's competing at, you're probably not going to be very successful non-operatively. But I still offer patients to say, listen, it's not 100% if you want to try it, try it. I don't go in immediately anyway, so I'll typically put them in a sling. We don't deal with external rotation slings. I think we used to. Do you use those anymore? Did you ever?
For a brief period of time.
Yeah,
but I
like
found,
patient didn't that.
exactly. I found that patients would say, Doc, you gotta be kidding me. There's no way that I could keep my arm out in this position.
Right.
I can't shower, I can't bathe themselves, you know, so it just is not.
Does not be so.
Right.
So that being said, that's not what we're here for tonight as conservative management. We're here to be aggressive and to operate this guy. So we're gonna operate this guy. I think that the standard of care here probably is still going to be arthroscopic. I think you're going to need the scope to evaluate the entire teeth. I tell patients in MRIs and digital interpretation of reality, you're going to get in there, and as Dr. Penn said, like, I bet you his posterior labrum looks like he's pulled off a little bit as well. This is going to be an around the world type of lesion. Even on the sagittal MRI makes me concerned because there's some high signal posterior inferiorly. So I wonder if there's a posterior lesion as well. And I think it's You can also evaluate, maybe take the arm out of traction. I mean, this is lateral position. I think this literature says that is. It's easier to do these in a lateral position, but you can take them out, put the arm in extrication abduction, and kind of get them up into that 90-90 position, see if that heel sac lesion comes into play. It doesn't look deep. It doesn't seem to involve a lot of the articular surface, so it doesn't particularly bother me. So I'm thinking here probably it's not unreasonable to do an all arthroscopic anterior posterior repair, be prepared around the world repair. I think I've gotten more. I know I've gotten more aggressive with non-standard portals for these to get down. I think it's very important to get down to the 6 o'clock spot. So you have to get comfortable on the shoulder, knowing where your axillary nerve is, where the safe spots are to go, and making really just percutaneous steps with 11 blades. I don't even put cannulas in sometimes, and just going through the deltoid and through the capsule with my suture passers and my anchors. So I think probably for the sake of this conference, we're going to say that you're arthroscopic. When I think, and then they'll come to me for the revision, and I'll put a ladder day on this guy at some point.
Okay,
So what we did.
So before we go to that, let's say he's not 27, but he's 18, senior year in high school, and it's preseason. First preseason practice, he dislocates the shoulder, has the same image, and now he comes in and says, "Doc, it's my senior year, and I want to play this year." My high school football player, D1 prospect.
Now that's all the or just recreational senior year. Well, that came in, and we're gonna all start to see this now. I had that kid yesterday, 17-year-old, and it's his junior year actually. But he actually had no apprehension, pretty amazing, full range of motion. So I put this kid in a sling out for a couple of weeks. I want to go to therapy as soon as possible. I want to see him back in 2 weeks. For those first 2 weeks, it's a matter of minimizing discomfort, increasing range of motion, restoring strength in a safe arc of motion. So I'm going to see him back in 2 weeks, re-examine him. Again, yesterday he had no apprehension, pretty remarkable, just 2 days after his dislocation. I'd like him to come back at 2 weeks, follow up and assess range of motion and stability or apprehension. And at that point, if he has regained basically full motion, nearly normal strength in the office subjectively, and he has no apprehension, I'm gonna allow him after his discussion with his parents, because he's 17,
Right.
If he wants to play, what position he plays, a running back, unfortunately. We're gonna get him a brace and put him in the modern Sawa or type of brace or selling brace, and see if we can get him back. Understand that I say you get one chance. If you dislocate again, then you're done for sure.
Right.
And if you go back, understanding you could do more damage, and then we're really in a different world. But if he's a Division I prospect, well, it's his senior year, he's probably gotten his offers, so he's probably set.
Yeah.
So we're going to fix him.
So we're
We're going to fix him for sure.
But if this is his last year of his football career, then you're offering the
I'm trying to get
opportunity
it
play.
back.
So do you have the discussion with him to explain that, because there are some studies now that say that the best opportunity is after your first dislocation,
Right.
and before the second. And if you allow him back, then I used to go the same approach, but now I do have this discussion with the patient and their family to say that the results for our surgery will be inferior if you dislocate a second time. So I think it's important to have that discussion with those patients, because there's some data to suggest that now. All right, so why don't we move on so we can get to some of the other cases. So I did an arthroscopic repair. So he actually, interestingly, it was more of a posterior lesion than it was anterior. So good pickup with both you guys. He did have an anterior labrum, which was around the world. The lesion went very far posteriorly. We ended up, I think, with 1 or 2 anchors anteriorly and 4 anchors posteriorly. And what I typically do with these is I will incorporate a capsular ship. I'll take a plication of the capsule and then go through the labrum and then incorporate it into a knotless anchor. And I like doing the knotless again because it gives a low profile. You can see we got a nice repair here. I can get my anchors. I do use if I want to get that 6 o'clock anchor, I'll use an auxiliary posterior portal and make sure, for one, to have a good drilling angle. So if you use the same portal that you use for your posterior, your scope insertion, it brings you very parallel to the space of the glenoid. So you need to have an additional posterior to do all these posterior repairs. And you can bring that very far inferiorly, just being conscious, like you said, about the axillary nerve. So this is what we did.
Yeah, I call it the 6 o'clock anchor. I think in my career, what I've learned the hard way is one, I like to put that in early on past the sutures. I'll often do a horizontal, try and really decrease the capsular volume with that. And I use an all suture anchor there because, and I don't typically tie that until after I've done my anterior repair. So I'll go in past sutures, leave them out, because I found I tied them, two things happen. One is,
And you can't see.
and two, when I used a regular anchor, then to my dismay, when I put my 5 o'clock anchor in the back or 7, in the front of 7 in the back or vice versa, and it's completely disheartening after you've done that, and then to see pop and watch that 6 o'clock anchor because your anchors converge.
Right.
And so I went to always putting an all suture anchor at 6 o'clock.
Right. I find I get mine very close. I think it's important to repair around to the 6 o'clock. When I go anterior and posterior to avoid that convergence, I will. I think I can get down to 5:30 and to 4:30. I mean, on either side. So
you're still using your latest iteration of your anchor, the bioabsorbable, not this two tensionable anchor.
Yes. Yeah, because I find that I can really tension and titrate how much I want to repair. I can incorporate plication suture, and so I've gotten very comfortable with it. All right. Any other comments on that case before we move on to the next one? So the next one, 34-year-old right-hand dominant male, right shoulder dislocation 6 years ago that required physician reduction, has not had another recurrent dislocation, but has pain with activities, feelings of instability with abduction, external rotation, no true subluxations, just primarily pain. But he's limited in a variety of sports, including tennis. So these are his x-rays. Not a whole lot remarkable here. And here's his MRI scan. So maybe we'll go back to
It's my turn. Okay.
Yeah, why don't we start?
So we have 4 views. Yeah, it looks like an MR arthrogram. Starting top left, we have 2 green arrows that are pointing out pathology. Looks like there's a strip, that the anterior, inferior, but I'm not sure anterior posterior there is stripped off. We can see some by extravasation inferiorly, probably go beneath the capsule. As we go down, the next one down low, we see that the anterior labrum is indeed stripped off. And then in the third image from the left, you see that there is indeed a Hill-Sachs lesion that is a little deeper and more concerning and than the prior image. And finally, the last image, we can see that really there is no capsulolabral bump anterior whatsoever, as compared to posterior. That's what that arrow is kind of pointing out to us. So it's really disconcerting. This is one of those that you worry about bone loss person. I think bipolar bone loss, and we have to have a good discussion with this patient of what their expectation is going forward, sports wise and life.
He wants to play tennis without pain.
Yeah,
because his shoulder's not dislocated.
Right, it's just moving around. And that's causing. He's probably translating. He's pinching his cuff or his capsule, and that's what's going on.
So,
and I'm not sure what's the third image too. Is his biceps okay? Is subscaps okay?
Yeah, subscap.
Oh, yeah, so the foot. You're good. Okay. So yeah, so here we go. We're not, he's tried everything. He's still trying to play tennis. We're gonna fix this guy. And
so I want to get to the third case. Would you do arthroscopic repair or ladder J on the patient?
I'm probably gonna still do the arthroscopic repair here, because his age, he's not a contact or collision athlete, and we want to. I still have standard care in this case.
Okay.
Yeah, I think we're less worried about another dislocation. We're more concerned about getting his shoulder stable enough so he can participate in overhead support. I think I would do it all arthroscopic, and I would just measure his Hill-Sachs preoperatively and see how far that is. But again, even though it's deeper, I don't know that one's going to engage very easily either.
Right, is a large arc of articular surface in the humerus still, so it's encouraging.
It's definitely deeper than the the last one.
But
So if you did an arthroscopic repair, would you do a ramp massage in this case?
Depending on
Tennis
the,
player, dominant arm?
depending on the measurements, but I try to avoid it, because I don't want him to have trouble with
excellent.
serving and overhead stuff.
Agreed.
Yeah.
I think I is very concerned with ramp massage next loss like sortation.
Yeah, I've actually been surprised as to how little loss of motion they have with a ramp massage. I've been very pleased with it, and I've been much more aggressive with ramp massage. But certainly something to think about.
What'd you do?
So here's what we did on this case was, we did an arthroscopic Bankart repair. I did a large plication. He had some bone loss. There was, you can see some articular cartilage damage. You can see it here in this view. And then I went ahead and I did a ramp massage as well using the tensionable knotless anchors. Was the case that I showed before. He had a fairly deep bill sacs. And I was, when I examined him prior to surgery, he was fairly unstable. I was a little more concerned that that he was subluxing more than he thought. And so I wanted to try and give him a little more stability. I thought that if we just did the Bankart, that I wasn't going to stabilize him well enough.
Did you advance, when you go back, did you advance his labrum up into that, I call it glad lesion?
I did,
articular
yeah.
defect, and
I did, and I did.
and that's a good example too, right? What you said of an ALPSA, like that's
Yes.
complete, like granulation tissue scar
Right.
peeled off chronically.
Yeah.
And sometimes they slide way deep.
We got
Right.
That you really have to look in the front to see.
realize,
Right, and so it's sometimes in order to dissect those out, I'll look from anterior superior and dissect from the anterior inferior portal because you can't really see it from posterior.
Yeah, I'll also like to, if I have an elevator or something to lift that up, the glenoid,
Mhm.
I'll go until you almost see a little bit of bleeding.
Right.
And you kind of know you're at the level of like the
Right.
subscap muscle.
Oh, yeah, I want to see a subscap fibers all the way down.
Yeah,
Yeah.
I mean, that's a very important point for
Got it.
arthroscopic Bankart repair. And I think that the reason why many of them fail is that people don't take enough time to dissect the glenoid ligament from the underlying subscap and really get a shift. And I'll sometimes get a grasper and really shift it superiorly. I'll take a tuck of tissue from as inferior as I can get with a curved suture passer and pull the tissue superiorly.
Yeah,
So-
I've gone to putting in a temporary, they call the pops, or the tops, a temporary traction suture up high and have my system pull
Right.
superiorly so I can really get that
Yeah,
bite down low.
yeah, because
As a person, I found it's very difficult to get that
A little.
suture passed down low.
I think that that technique is very important when it comes to success of arthroscopic Bankarts. And the reason that you see kind of a broad, recurrent rate across the literature is because of technique. I think that some of the things that we've learned about the technical importance, shifting proper position of your anchors, really makes a difference in success rate.
So this makes me more nervous
Is that right?
about this patient. Yes.
Yeah.
No, I'm saying, like, personally, I'll leave there being like, wow, that was a lot worse than I expected. Again, that's a digital interpretation of reality, right? We go in and say, wow, you had a lot more. We didn't expect that to do that ramp massage, but you needed it.
Right.
By the way, guess what? You have articular cartilage damage. The shoulder's already kind of like, this is going to give you problems in the future. You're going to have an upgrade shoulder here in the next couple of decades,
All right, so I think we have time for this one last one, even though it's a very complicated case. This is a patient that I'll try to run through it if we can, because I think it's important to realize that shoulder instability runs a full gamut. And this is always the nightmare patient for orthopedists.
This is very
This is a real life patient.
common. Yeah.
Patient that I know well, actually. 17-year-old right-hand dominant male with seizure disorder, not involved in sports, had multiple recurrent anterior dislocations, all requiring physician reduction. All dislocations occurred during seizures, and he was completely asymptomatic between seizures. This was his first dislocation at age 17. You can see his growth plates are still open. He already has a very large Hill-Sachs lesion here. So, just so we can kind of get through this and being respectful of everyone's time, I would assume that everyone would say initially that since he's only symptomatic with dislocation, with seizures, that the first step is to see if we can control his seizures better, have him speak to the neurologist. Would anyone at this stage jump in and say, we need to do surgery? He's had multiple dislocations. The parents are distraught. They're kind of are forgetting a little bit about the seizure disorder. They're saying, we have to take him to the hospital every time he recovers from a seizure. We're putting his shoulder back in. And, so is there something you could do?
He's got bigger problems than this
Right.
dislocated shoulder. I think that this is, I've seen this. We see this stuff far too often. This is actually a big problem.
Right.
And yeah, seizure control was ideal.
Part of the problem is that the parents kind of focus on the instability,
Correct.
and they don't recognize that regardless of what we do, this shoulder will likely dislocate it if you can't control the seizure.
Yeah,
Right.
exactly. Right. But
So
there are
you
those
have to
patients you can't control seizures. That's the tragedy of it all. And,
So the family was a wonderful family, intelligent and good conversations that we had. We were able to convince them that they needed to manage his seizures. Unfortunately,
wow.
for 8 years, he was seizure free. Once the neurologist was able to get him under better control, he was asymptomatic, no seizures, no dislocations, full activities. Then 8 years later, he had his first seizure and dislocated his shoulder once again. So again, I would assume that everyone would say, okay, we had great success. Let's see if we can get your seizures back under control. We still wouldn't operate, even though, and x-rays pretty much looked the same. So then the story got worse. He was swimming on vacation 4 months after his first seizure in 8 years, dislocated his shoulders, the first non-seizure related dislocation, had a second dislocation a week later with a trivial movement while rolling over in bed. So pictures, here we go.
That's definitely a warning sign, I think. When anyone tells you they dislocated in bed, then I feel like that's a very unstable shoulder function.
So here he was. Now you can see he's skeletally mature. You can see the Hill-Sachs lesion is about the same, maybe a little bigger.
Yeah.
And here's his MRI scan. All right. Interestingly, I thought that I was expecting more glenoid bone loss, but you can see not quite as bad as I thought. Here you can see the large Hill-Sachs lesion. And then here's some CT scan reconstructions.
He does have glenoid bone loss, though.
He does.
It's not.
But
It's not as bad as
I thought.
Hill-Sachs.
You
It's
would
Hill-Sachs.
think with all these, right. So now what do? He's anytime he comes out of his sling, he feels unstable. He's extremely apprehensive.
I mean, I think that
And they've gone back to neurologists. They said we still need to get his situation under control. He then went on to being about 8 months seizure free, and still extremely unstable. So, what would you recommend at this point? And how would you approach this? And I want to preface to say that this is an extremely complicated case. I don't think there's one right answer on this one particularly.
Yeah. I mean, my training at Jefferson, he probably would have gotten a bone grafting of his humeral head, and then possibly also ladder J, or an open Bankart while you're bone grafting. So we'll just open the shoulder joint and then rotate the shoulder enough to get access the Hill-Sachs lesion, bone graft it, and then do the anterior procedure.
And the anterior procedure that you would
Probably
prefer
ladder
would be
J.
a ladder J.
Yeah.
Okay. Greg, you do a ladder J on?
Yeah, so these are the ones I really don't want to use hardware, a little hard as possible. I think we're gonna want to get a bone graft. He's now still less than 30, right? So under 30. So probably get a bone graft, humeral head or femoral head, want to shape it down. If you can go bioabsorbable headless screws, maybe, to avoid metal screws in the bone graft posteriorly, because you worry about if it puts something dislocate, if he seizes again, or that graft reabsorbs. It'd be nice not to have the metal in the back. I think
But would you use a free bone graft or a ladder J?
No, no, I'm talking about the Hill-Sachs. I'd use it.
Okay.
I would bone graft that Hill-Sachs, and then anteriorly. Again, if we're gonna do a ladder J, then I'm gonna want to use buttons in this case, and I won't feel as bad using the buttons, which are not great against shear, if we've done the bone graft of the Hill-Sachs. So I'm not going to use screws, is what I'm saying, anteriorly for a ladder J. But I would probably just do an open Bankart, soft tissue. I think we filled that Hill-Sachs, and And just, again, I want, in this case, less is best, just afraid of putting too much stuff in there.
Mhm.
I don't know if, I mean, I would like to increase his groin arc, but if I'm gonna do that, then I'm doing a 2 buttons, not 2 screws. And I don't know if I'm using his own wires or if I'm using just a iliac crest or something else.
Right. Well,
What'd you do?
what was done was an open with iliac crest needed it with the neck. So
And did you do anything in the hill since you did not?
no,
All right.
it's widening the arc. This was after conferring with a colleague at Hopkins. This was the preferred procedure. And there he is, and then here he is 6 months later. Looks like we've gotten good healing.
Yeah.
And he has remained seizure free, and shoulder is stiff, but he's stable.
Huh.
So, like I said, there's many ways to
Skin the cat.
skin this cat.
I love lateral agility, but this is what makes me scared.
So I think I have other cases, but I think we've run out of time.
There's some
I think this is a fun discussion. Appreciate everyone's attention, and thank you to our panelists. I think you can see that this is shoulder instability is clearly an exciting topic. It's one that I think continues to evolve. We have these discussions in our conference rooms frequently, talking about the different advances. And again, I think the future still is with the arthroscope, but I think we're learning more about the importance of bone loss. And I think that the future advances, standing on the shoulders of the giants behind us, are to that have come before us, are to learn to perform these procedures and some of the address some of the bone loss that we've talked about arthroscopically in a more efficient and effective fashion. I think we'll start to see another paradigm shift in our treatment. But I think this continues to be interesting and continues to be an exciting topic for us all. So, any other closing remarks anyone might have?
I will say that this is all very eye-opening to me, seeing, and I think bone loss is probably the biggest consideration, it sounds like, in pathology that's involved in the recurrent or single time dislocation. But just the
we see differences in how you have to rehab those patients.
I mean, again, it's probably more surgeon dependent based on their protocol and what they're most comfortable with doing. I mean, protocol, someone with a larger anterior stabilization procedure, it's a lot slower with external rotation. I'm going to put a lot of emphasis on anterior muscular development, strong lats, pecs, subscap to help back up that stabilization. Posterior labral repairs might delay some of the posterior cuff work we do, not pushing as much in some range of motions, but I mean, I think, again, more surgeon dependent on speed of protocol, but I think number one is probably that nature taking its course and the structures healing and restoring range of motion slowly.
Right.
But I think the biggest, down the road point on our end, especially when you're getting to that overhead athlete, someone who's more active, rotational type athlete, is that a lot of the literature looks at in the battery of testing that you do to return someone, that athletes who return to sport without some type of multifactorial testing battery are 4 to 5 times more likely to have recurrent issues with that shoulder. So having, a multifactorial stepwise progression of testing and returning to whatever sport it is, graded exposure is crucial to long-term health of that stabilization procedure. So, and it's going to be sport dependent too. So the way you decide on returning a baseball player versus alignment is going to be different. Or someone who has, maybe you have alignment, it's a lot of pushing and had a posterior labral repair for posterior instability versus a pitcher, swimmer, tennis player who have that anterior recurrent instabilities.
Right, okay. I guess we should, since there are some people watching virtually, we should open if anyone has any questions or comments that they have, and then we'll sign off and hope that others will join for future talks that we have in the lecture series. All right, well, if there aren't any other questions from virtual, we'll sign off and appreciate everyone's attention, and hope you can join us for future talks with our lecture series. Have a good evening, everyone.
Thank you.
Thanks.